request Dr. Gomati ma'am to please be on the stage, as ma'am will be the examiner for the next case as well. There's a slight change in the order of presentation. Next, we'll be having the long case presentation by Dr. Kavita from Nephrology Urology Hospital, Bangalore. May I request Dr. G. Swarnlata ma'am, Professor and Head of Department, Nizam's Institute of Medical Sciences, to please be the examiner for the next case with Dr. Gomati ma'am. Dr. Kavita, please.
Okay, so all the best and start your presentation.
Thank you. So I'm presenting a case of a 50-year-old female. She is resident of Gudiyatam, which is near Vellore. She's a homemaker. She has come for her regular hemodialysis session, on hemodialysis since 5 years. I would date back my history to 17 years back, in 2006, when patient was diagnosed to have diabetes mellitus during the 24th week of her second pregnancy. She was a booked case and she was 33-year-old at that point. She was diagnosed to have diabetes mellitus and initiated on oral anti-diabetic medications and insulin. There was no history of any increased thirst, increased urination, abdominal pain, frothy urine. Her blood pressure was normal. She remembers her blood sugar to be 260 and HbA1c she is not aware. She was initiated on medication and it was brought well under control. There were no episodes of hypoglycemia. Patient completed her term and delivered a female child of 2.2 kgs at 38 weeks with LSES. Indication she remembers to be small for gestational age baby. Baby cried at birth. Patient sugars postpartum continued to be high and she was advised to continue medications. Patient was regular with follow-up for sugars with her obstetrician for almost 5 to 6 years, and she remembers her sugars to be well under control. She does not remember getting evaluated for proteinuria, renal function, or eye examination. After 2012, patient was lost to follow-up for 3 to 4 years, and she stopped all her medications till 2015. She started noticing swelling of bilateral lower limbs up to ankle. It was not associated with frothing of urine, periorbital edema, breathlessness, or abdominal distension. She also recollects having burning sensation of feet of bilateral feet. There was no history of any chest pain, dyspnea on exertion, pain on walking. Eye examination was not done. Her blood pressures were normal. She met her local physician and she was told to have uncontrolled sugars, remembers her sugars to be 360, and was reinitiated on oral medications and insulin for the diabetes. She was regular for follow-up thereafter, and her edema subsided within few days. She does not remember details of other medications given, and protein leak and renal function was not evaluated. Patient was on follow-up till 2018, and she developed again bilateral pedal edema. This time not associated with breathlessness or periorbital edema. She was told to have protein leak in urine and was told to have renal dysfunction with a creatinine of 5.4. She was advised renal biopsy in view of renal dysfunction and underwent biopsy, which was uneventful. And she was told to have advanced kidney disease related to diabetes and was advised initiation of hemodialysis at this point. There was no history of fever, burning sensation of urine, abdominal pain, NSAID or alternate medicine intake. She was advised initiation of HD, but it was deferred by the patient. 6 months post-biopsy in 2019, patient noticed worsening of the pedal edema. It was associated with vomiting and poor intake over days, breathlessness on exertion, and on presentation to the hospital was told to have hypertension. She was initiated on hemodialysis via non-tunneled HD catheter into the right IJV and was continued on twice-a-week hemodialysis. Does not remember her dry weight with interdialytic weight gain of 2 to 3 kgs. She was initiated on hepatitis B and pneumonia vaccines, iron injections, and erythropoietin. She does not remember her urine output. Subsequently, patient underwent a left wrist AVF creation, which was non-functioning immediate post-procedure, and hence her dialysis was switched over from the right non-tunnel catheter to a tunnel catheter. And around the same time, a left elbow AVF was again tried, but it was non-functioning post-procedure. She also remembers having flow issues in the tunnel catheter, and she was told to have some blockage and layer formation, for which she required exchanges of the catheter, and also once a temporary catheter was inserted into the right thigh. She does not remember any injections being instilled into the catheter, and she remembers the catheter was exchanged a couple of times in that year. There was no history of fever or any emergency admissions, intradialytic events. After 2 years into the dialysis, she had a successful left mid-forearm fistula creation, which was functional after 3 months of creation, and her dialysis was switched over from the tunnel catheter to the left mid-forearm fistula, which is the current axis. Patient remembers discontinuing her insulin 3 years back and was also diagnosed to have hypothyroidism at that point. She was also told to have cataract in the left eye, and retinopathy status was not checked. The last event was 1 year back when patient noticed sudden onset facial puffiness and breathing difficulty over 1 to 2 days, requiring ICU admission. She was regular with her dialysis sessions till that point. She was told to have blockage in the major vein above the heart, and she underwent an emergency procedure through the right thigh, and the blockage was relieved. HD was continued via the left forearm fistula. There was no flow issues in the fistula. There was no increased pressure or increased bleeding post-closure or any recurrent alarms. So currently, patient is on twice a week hemodialysis with a dry weight of 72.5 kgs, interdialytic weight gain of 3 kgs. She's continued on her regular antihypertensive, anti-diabetic, iron and Vipox medications. And her urine output is approximately 200 ml per day. She has been explained about cadaver donor transplant, as she has no potential donor in her family. She is yet to register for it.
Over your present history. How about the other history? You want to complete or?
Yes, ma'am. Vaccination history. Patient has been vaccinated for hepatitis B. She does not remember her titers, pneumonia, and COVID vaccine. Medication history. She is on 2 antihypertensive medications, 1 anti-diabetic medication, phosphate binders, thyroid supplement, soda bicarb, antiplatelet, and a diuretic. Past history, she's had appendicectomy 30 years back and tubectomy 33 years back. Personal history, she's a non-alcoholic, no smoking history. She takes mixed diet. She has constipation since few months, not on any medication. Bladder is normal with an output of 200 ml per day. Obstetric history, she has had history of primary infertility in the initial 5 years post-marriage, following which she had first pregnancy, which was full term and normal delivery. But there was some renal issue with the child, and the child passed away within 1 week of delivery. The child was advised hemodialysis, but patient deferred it, and the child passed away after 1 week of delivery. The second child is passed away at the age of 14 years. It was a LSCS due to fever and infection-related causes. Family history, she has 1 younger sister who is healthy, no history.
Talking about the sibling of this patient? Or
Yeah, family history.
Family history.
Obstetric is 2 children, and both are not alive now. And her periods have been regular. She has attained menopause 2 years back. Family history, 1 younger sister who is healthy. Father and mother both have passed away. Father and mother both are non-diabetic. Father had MI at 50 years of age, and mother had malignancy. She's not able to tell the type of malignancy.
Okay, summarize.
Is a 50-year-old female with long-term diabetes mellitus and a microvascular complication in the form of biopsy-proven diabetic nephropathy, neuropathy, hypertension since 4 years, hypothyroidism 2 years, currently on hemodialysis via left mid-forearm fistula with multiple access failure in the past, and an episode of central venous stenosis 1 year back.
And dialysis vintage?
5 years.
5 years, okay. So you said patient was initially diagnosed to have a gestational diabetes, no?
Yes,
During the second pregnancy. How about the first pregnancy?
First pregnancy, she did not have any hypertension or diabetes.
It was uneventful?
Yes, ma'am.
And you also
Actually,
had a history, like you said, she took treatment for some infertility.
no, she was infertile, but she had not taken
So
any
not taken
treatment. She
any,
conceived spontaneously.
spontaneously, the first one. The second one?
Second one was also
What is the difference between the first and second child?
4 years.
Okay, and no medications. She
No
has not taken any
medications.
medications. Okay. So how to define gestational diabetes?
Gestational diabetes is defined as a fasting sugar of more than 92 or 1 hour post GTT, post OGTT of 180 or 2 hours post OGTT of 153 milligram per deciliter.
Duration with respect to, timing with respect to the pregnancy?
The second trimester.
Second trimester? And is there any relation like after delivery? What should happen? What should the natural course?
Natural progression, most of the GDMs resolve postpartum. A few of them continue. And they also, even if it resolves, they also have a high risk of developing diabetes in 10 years' time after the delivery.
What is the timeline? When do you call it as gestational diabetes? Okay, what happened to this lady?
She actually continued to have diabetes even postpartum. And was continued on medications.
Okay. And you said 2012 she has stopped all medications,
Yes, ma'am.
isn't it?
2012 to 2015.
Okay, and she delivered
Delivered in 2006,
2006.
last
So she
pregnancy.
was on medication almost for 12 years, and after that she has stopped.
6 years.
6 years
6
after
to
that she has
2012.
stopped. Okay. So, and you said she had presented with a swelling of feet and face and breathlessness,
Yes.
isn't it? So what do you think is that a cause of presentation?
She was not on her medications for diabetes, and she also had burning sensation of feet along with that symptom. So, likely to be diabetic nephropathy, proteinuria.
Is it a natural cause of diabetes with diabetic complication or something other? I mean, the other some glomerular disease, non-diabetic glomerular disease.
In her case, when she presented with this, she was already 10 years into diabetes with a non-compliance history of 4 years prior to the presentation. So this is possibly diabetic nephropathy.
You also said there's one, about the blood pressure. You commented about the blood pressure.
Yes, ma'am.
So is it normal or abnormal?
In the first presentation of pedal edema, she does not remember, but she says it was normal. Only during the second presentation in 2018, when she had very severe symptoms of breathlessness, she was told to have hypertension.
So, but what will happen in natural course of a diabetic when they attain a diabetic nephropathy? What should happen to the blood pressure?
There should be hypertension.
So that is actually a first sign of patient landing up in diabetic nephropathy, isn't it? Okay. So when do you suspect a non-diabetic kidney disease?
Non-diabetic kidney disease, if the duration of diabetes, mainly in type 1 diabetes, if it presents less than 5 years of presentation, or at the time of presentation in type 2 diabetes, and if there is rapid worsening of GFR, or there is massive proteinuria, or there are active urine sediments. Or there are other systemic features of renal disease.
What is the correlation with retinopathy?
If retinopathy is present in 90% of patients of type 1 diabetes and 60% of patients of type 2 diabetes. So, if retinopathy is present, there is a likely chance that the patient has nephropathy, but if retinopathy is absent, it cannot be ruled out otherwise.
During the first presentation, you were telling that the sugars were uncontrolled. Is it very common to have uncontrolled sugars with the onset of renal dysfunction? How is insulin metabolized?
First, in 2015, there were uncontrolled sugars because she had lost to follow-up for 4 years. At that point, she was not evaluated for renal function. Renal dysfunction had happened 3 years after that. With onset of renal disease, the requirement for medications, mainly insulin, will be low, and patients will have more normalization of the sugars,
Why?
rather episodes of hypoglycemia.
Why?
One is the half-life of insulin is increased.
Due to?
Because it is also partly metabolized in the kidney.
What percentage of insulin is metabolized by the kidney? Any other reason?
Renal neoglucogenesis is impaired,
Okay.
and also there is defective counter-regulatory hormones.
Then, the onset of renal, what will happen to the appetite?
Appetite will be low.
Then autonomic neuropathy.
Yes, that is
All this can-
hypoglycemia unawareness. They will not have symptoms of
Then half-life of OHS also will be prolonged.
will be prolonged.
When will you evaluate the patient with diabetes for diabetic nephropathy?
Type 1 diabetes after 5 years of detection of diabetes. Type 2 diabetes at the presentation and annually thereafter for proteinuria and GFR drop.
How often you check proteinuria?
Annually.
Initial, not annual. Initially you have looked for microalbuminuria.
Yes.
How often, when will you confirm? With single measurement you will confirm?
2 values 3 months apart.
3 values, 2 out of 3 should be positive.
Is it 3 months or
3 months or more, 6 months.
so 2 out of 3 values over a period of 6 months?
6 months.
What is that classification called? What is that definition of microalbuminuria called? Okay, now how do you look for microalbuminuria?
Can use urine dipstick.
This diptych should not be used actually.
And urine analysis for proteinuria.
How do you analyze? How do you collect the sample? What do you mean by timed urine collection, timed urine sample?
For microalbuminuria spot urine analysis, early morning sample can be taken. Otherwise, 24
Time
hours.
sampling, you mean to say early morning sample?
Time sample is 24 hours sample. After the first void, we have to start
So
collecting.
it can be 24 hours, it can be 12 hours. It's over a period of time. Okay. And you take early morning sample or second sample?
For the timed collection, first
No, timed is different. You are getting confused. Time is you collect over a period of 12 hours. It can be 24 hours depending upon the patient convenience. Sometimes it's very difficult to collect over 24 hours.
for the
You are looking at
spot.
spot. Is it first urine sample or second urine sample? In what
Second.
situation you go for a first urine sample and in what situation you go for a second urine sample?
Not aware.
Okay. And you said, definition of microalbuminuria is 2 out of 3 samples should be positive. What are the other conditions you should rule out before you label it as microalbuminuria?
Active infection.
Not working, huh? Or you can give a hand mic. That's better.
Ma'am, we have to rule out stress states, fever, pregnancy, active infection.
So yes, all those should be ruled out because even exercise, fever, all those things can also cause a microalbuminuria. Okay? Okay. So when a patient has presented to you, we need to look at.
First is history
Okay.
and physical examination. Ask for the compliance of medications or any other alternate medicine intake. Then examination mainly to look for pressures, edema, and
No, because you said, see, presented with sudden swelling of feet and breathlessness.
though the first one was
So-
over days, ma'am. The second one was sudden. That's why she was initially on
And how
urgent.
long she has stopped this medication before
4
presenting
years.
to?
4 years.
4 years she was completely off, or she
Yes.
was taking and then only few days she has stopped and she has come back.
No, she had completely stopped because her primary physician lost to follow up with the primary physician.
So how do you evaluate
Um,
at that particular point of time?
pedal edema and she presented with pedal edema and burning sensation of feet. So primary evaluation in the form of urine analysis, renal function, GFR calculation, ultrasound abdomen, retinal examination, blood pressure, check for blood pressure, and also a cardiac evaluation.
Okay. No, I think because she was off medications for so long
HbA1c
and
and
suddenly she has
sugars.
presented, I was actually looking for any other reasons for her clinical condition, whether it's something like glomerular or could be AKI.
So
Of
there
course,
was
one point what you said is burning of feet, and that
yes.
of course probably that is a complication of diabetes. But sudden presentation with breathlessness and then swelling of feet. I mean,
That
I
was a
would,
second presentation, 3 years after the first edema. So there were 2 presentations of edema. First one was not with breathlessness, no hypertension detected. She was restarted on medications. 3 years after that, again she had an acute presentation. That's when the biopsy was done.
And how do you, for example, like, okay, TK, so 2012 when she had a presentation, so you have to evaluate with respect to glomerular, I mean other glomerular disease also. You have to look for the complement and then the
Yes.
all the serological evaluation. TK. At that point, you strongly feel it is diabetes only. So how do you treat that patient?
First is to bring pressure and sugars under control, and then mainly advice regarding diet and fluid, salt restriction, lifestyle, weight reduction, then proteinuria if it is proven, then we
Okay,
can
so
start on
non-pharmacological and now pharmacological.
pharmacological. Then start on AC or ARBs based on the potassium levels. And
What is the evidence?
for AC ARBs, we have multiple trials
So
starting
what are
with
the evidence to
captopril.
show that strict blood sugar control, retards the progression of the kidney disease?
Ma'am, the
Major trials,
earlier
landmark
trials,
trials.
UKPDS and DCCT.
So what is the cutoff for this HbA1c levels they have advised as per those trials?
7.2.
7 points too high.
They had both arms, intensive and conventional.
Mhm.
So intensive was 6.2 and 6.6 and 7.2. So the intensive arm had more complications, and hence.
What is that trial where intensive had more complication? And they have said this is the cutoff, beyond this you cannot go, you should not reduce the blood sugars or HbA1c.
UKPDS. Accord.
Accord trial, they are given a cutoff of 6.5. HbA1c was 6.5. Okay, so blood sugar control is the one measure. Next. So these are the major trials for the blood sugar control.
Yes. Then second one was control of blood pressure and proteinuria. Also prevented the progression of renal disease and cardiovascular outcomes. So that was based on the AC or ARB related trials, starting from captopril Levi's trial, and then irbesartan IRNT, then
IRMA trial,
renal
IDNT
trial, including losartan.
Any trial which showed that these ARBs and ACRB inhibitors have worse outcome on this diabetic nephropathy patients? So most of the study are
Combination-
positive trial. They have shown that
Yeah.
they will try to reduce
Yes.
retard the progression of disease, kidney disease, diabetic kidney disease.
There was a trial which showed combination is detrimental, but I don't remember the name.
On target trial.
On target.
So you not use both drugs simultaneously.
Yes.
But what is the caveats of that particular trial?
What is the?
What was the shortcoming of that particular trial? Okay. Next.
This patient had gone into end-stage kidney disease and was initiated on twice weekly hemodialysis. So she had undergone 2 times fistula creation,
Yes.
primary non-functioning fistula. So what would have been the reason for non-functioning primary failure of AV fistula in a diabetic patient? What all things you should do to evaluate the patient? History, physical examination, like that.
Primary non-functioning risk factors in a patient include female patient and duration and control of diabetes.
What are the important salient features in the history? History you will ask.
Features of peripheral vascular disease in the form of recurrent ulcers in the feet, and
How do you look for the adequacy of the circulation in the palm? What test you will do?
Allen's test.
How do you do the Allen's test?
Um,
In fact,
The-
what is it meant for? Allen's test is for what?
to see the adequacy of collateral supply through the ulnar artery, so that we can take up the radial artery for puncturing for creation of AVF. So Allen's test is done. We ask the patient to create a fist, and then we compress both the radial and ulnar artery, and then ask the patient to clench the fist a couple of times so that the hand is blanched, and then we have to release the pressure on the ulnar artery and see for the return of color to the arm, hand, within 5 to 15 seconds.
What are the other investigations you will do to assess the vasculature prior to proceeding with creation of AV fistula?
Uh, if a patient is diabetic and we are suspecting that the vessels may not be normal, we can do a Doppler of the veins, also to check for the distensibility, flow, and size.
What should be the minimum size required for artery and vein?
For artery, it is 2 mm, and for vein, 2.5 mm.
Okay. What are the causes of primary non-functioning of the AV fistula?
One is thrombus formation. Juxtaanastomotic stenosis, but that will not
Yes.
be very early.
Then inflow, the feeder artery.
If there is hypotension in the perioperative,
So it can be
period.
classified as at three sites: inflow, outflow tract stenosis, and the accessory veins, tributaries stealing the blood down, deeper veins. Okay. In addition, calcification. Diabetic patients, they have increased risk for calcification. So this will preclude the distension of the vessels following creation of AV fistula. Okay. Okay.
Okay. So the second time when she presented, you said she underwent biopsy then.
yes,
So though my preference would have been biopsy the first insight itself after the evaluation for the non-diabetic kidney disease. So why do you think second time she underwent a biopsy?
the first
What
time.
was the, if at all biopsy is indicated, so in which situation you do biopsy?
The first time she remembers pedal edema and burning sensation. There was no hypertension, and she remembers not being evaluated for proteinuria and renal function. But the second time it was an acute presentation, and the first creatinine known to us was 5.4. So they wanted to rule out any rapid worsening of renal function, and also there was significant edema. So she was advised renal biopsy.
So you were to say the unexplained worsening of the kidney function was the indication. The other indications be?
Other indications, if there is rapid worsening of GFR, if we know a baseline.
That's what she
And,
underwent biopsy. The other what you meant trying to say, what are the other indication of a biopsy in a diabetic kidney disease?
Rapid worsening of proteinuria,
Proteinuria, massive proteinuria,
active urine sediments,
active urine sediments.
absence of retinopathy can be one, and other systemic features like any fever, joint pain, rash, or systemic illnesses around that time.
So hypocomplementemia.
Yes.
Okay, take care. So what do you think the biopsy findings would have been in this patient?
She was told to have advanced disease of the kidney due to diabetes, so likely to have class 4.
Class 1. And how do you classify?
So class 1.
Histopathological classification.
Class 1 is GBM thickening. It can be more than 395 nanometer in women and more than 430 in men.
So how do you say membrane is thickened?
The electron microscopy.
Okay.
And
And if you don't have electron microscopy, light microscopy, if you want to assess,
We cannot measure it, but light microscopy can also show thickening of the
so we compare with the
tubular
globular
basement
basement
membrane.
membrane. ठीक है. Then second stage.
Second is 2A and 2B. 2A is mild mesangial expansion, which is involving less than 25% of the glomeruli, and the width of the expansion will be less than the size of the capillary loop. 2B is moderate mesangial expansion, more than 25%, involving more than 25% of the glomeruli, and the size will be more than the size of capillary loop. Class 3 will be at least one Kimmel-Still-Wilson nodule, which is a large mesangial expansion with a nodular formation due to hyaline deposits. And class 4 will be global glomerulosclerosis involving more than 50% of the glomeruli.
So what are the other different diagnoses of nodular sclerosis, KW lesion?
Monoclonal immunoglobulin deposition disease, idiopathic nodular glomerulosclerosis, fibrillary glomerulonephritis.
How do you differentiate?
Fibrillary, we have this.
No, in general, diabetic, you said KW lesion, how do you differentiate with others? What staining you'll ask for?
For amyloid, there will be Congo red stain.
ठीक है. But here you're talking about diabetic.
Diabetic past stain will be positive.
This is, it's actually seen there, no? Read this.
This is the HNE stain showing two glomeruli, and the glomeruli show mesangial expansion with hyaline deposits, and also there is thickening of the glomerular basement membrane. The tubules are not opposed back to back, so there is tubular atrophy, and also interstitial inflammation with mononuclear cells.
Okay.
Vessels.
Yes, ma'am?
Vessels, comment upon the vessels. What are the findings in the on the light microscopy which tell you that maybe diabetic nephropathy? You are not given a clinical history, you are given only the histology. What are the findings in the biopsy which may tell you that maybe this is diabetic nephropathy? What are the findings suggestive of diabetic nephropathy?
Hyaline thickening of the vessels.
Which vessel?
Arterioles.
Which
vessel?
arteriole?
Now it is in hypertension also, particularly there is a history of CNI usage. So then how do you differentiate because of CNI, diabetes or hypertension?
The hallmark will be KW nodules.
No, I mean you're not talking about the glomerular,
Vessels.
only vessels. Madam has told about vessels.
Vessels.
Which vessel will show the hyalinosis?
What is hyalinosis?
Hyalinosis is deposit of hyaline material in the wall of the.
What is this hyaline material?
It is.
ठीक है. So in the efferent arteriole they'll have hyalinosis in case of diabetic, whereas efferent will be in case of hypertension and CNIs. Okay, CNI toxicity. Okay, so here the biopsy is showing.
Other features are probably capsular, hyaline cap and capsular drop.
Fibrin capsular drops.
Okay, in fact, this report shows one glomerulocellular crescents also. So there is this is the same patient, the previous patient.
That is a previous patient.
Previous patient.
This
Okay,
is
this is one. That's what I was wondering. Okay. Okay, so what is your diagnosis with the biopsy?
Ma'am, I was biopsy was not given.
Okay, no, you
Acha,
can,
this
you
one,
can
okay.
see and then you can tell, no?
And this is class 3 diabetic nephropathy.
Class 3 or class 4? What is the difference between class 3 and class 4?
Class 4 will be more than 50% global glomerulosclerosis. Here both the glomeruli are not yet sclerosed.
It's a glomerular sclerosis or tubular interstitial changes also?
Tubulointerstitial changes is not mentioned as per the glomerular pathological classification. IFTA more than 50% is class 3.
Okay, so more than 50% is class 4.
Class
Okay, so less than 50% is class 3. Okay, so that was about the diabetic, the biopsy is confirmed as a diabetic kidney disease. Okay, then how will you manage then? Creatinine you said is 5.4, isn't it?
At that point, first is to rule out any acute events or control the blood pressure and sugars, and then medications.
So you have done that. You have blood pressure is under control, so diabetes is under control. Any newer drugs? Of course, not at this stage where creatinine is 5.4. So what are the other drugs which can be used?
First is ACARBs to reduce proteinuria and progression. Then in the diabetes medications, we can start with first line is metformin, and then SGLT2 inhibitors. Then third line would be non-steroidal mineralocorticoid antagonists.
So what is the evidence with respect to SGLT inhibitors?
The trial Fidelio
I'm not talking MRS.
in SGLT, ma'am. SGLT2 we have 3 trials: EMPA kidney, CANVAS, and EMPA reg.
I mean, these trials were designed basically for what was the primary endpoints and secondary endpoints?
It was mainly done to see the outcomes on cardiovascular and then progression of CKD. So it was beneficial for both.
So initially it was a cardiovascular.
Cardiovascular.
Endpoint was a cardiovascular, but in fact this cadence trial was stopped prematurely because there was overt what you call benefit, the beneficial effect was seen with respect to even the cardiac, the renal endpoints. Okay. What are the other evidences apart from credence trial?
Other
Trials apart from credence?
CANVAS,
Okay.
EMPA kidney, and EMPA reg.
EMPA-REG is? EMPA is again cardiovascular.
Yeah.
What are the side effects? Before you start, what are the things you should look at?
We have to counsel the patient about sick days and to see the GFR. GFR should be more than 20 ml before we initiate. And
25 was the cutoff in all these trials.
and then we must educate them about genital infections and also that there is a possibility of worsening of GFR less than 30%.
So
Blood
UTIs,
pressure,
genital infection,
drop in
and
blood
then-
pressure,
okay.
hypovolemic risk. So we have to see the other drugs which we are prescribing along with it.
Okay, the other drugs, newer drug?
For diabetes, we have GLP-1 receptor analogs. If the sugars are not under control after first two line agents of metformin and SGLT2, the third line would be GLP-RA analog, receptor analogs. And for blood pressure and prevention of worsening of CKD, we have the mineralocorticoid analogs,
What are the two major trials?
Fidelio and Figaro. Fidelio was done with Finrenon to see the outcomes on renal disease, and Figaro was done for cardiovascular effect of these drugs. and both are positive.
What is the difference between the newer agents and the older agent which we used to use almost a
The
decade
risk
before?
of hyperkalemia is less with these agents, and even these are non-steroidal.
Okay, ठीक है. Now you have declared the patient as ESRD. So how do you manage, and what are the instructions you give to the patient? So of course, madam has told you about all this access. Apart from access,
Patient has to be on regular hemodialysis with annual check for a cardiac
before that,
blood pressure to be kept under control, sugars, and also awareness about hypoglycemia.
vaccination. What
Vaccinations
vaccination you want to
she has
consider?
completed. Vaccinations.
What vaccination do you need to consider?
Hepatitis B, pneumococcal, and flu vaccine. And zoster in elderly people with risk.
Okay. You said this patient was admitted for a sudden onset of breathlessness in the background of multiple access failure. If she develops the similar symptoms, recurrence of similar symptoms, what will you consider, what will you evaluate for in this patient?
Recurrent episodes of accelerated hypertension, breathlessness, we have to rule out renal artery stenosis.
Okay. How will you rule out renal artery stenosis? And how will you manage? If suppose if renal artery stenosis is identified by Doppler, how will you manage?
First, we have to see the control of blood pressure with medications. If the blood pressure is well under control, then we can manage it medically. Also, we have to see the kidney sizes and the renal function.
Even with a normal blood pressure, can you get pulmonary edema in renal artery stenosis? Do you require hypertension, severe hypertension?
No.
Okay. The mechanism is slightly different. It is not hypertension induced LV dysfunction. Okay. Then if the
since
BP is well controlled with drugs, then
in this patient, since he is already on ESRD, any more intervention is not required if there is renal artery stenosis, if we can control the blood pressure with medication.
okay. But if she has severe pulmonary edema, recurrent episodes, distressing,
Then we can either plan a renal artery denervation or nephrectomy.
what are the findings which will tell you that the renal artery stenosis intervention is going to be effective or reversibility, effective? One, you said the size of the kidney. What is the cutoff size?
1.5 centimeter difference. If it is more than there is a difference of more than 1.5 centimeter.
So 8 centimeter.
The total.
Okay, total length.
Then captopril renogram.
You said the answer earlier, proteinuria. If there is significant proteinuria, it's not going to be reversible. Next is Doppler indices.
Peak systolic velocity more than 160.
More than 200. Right. So these are the some of the parameters which will tell you that if
Will
it
not
is
be reversible.
okay. Then what is coral reef aorta?
Yes, ma'am.
Coral reef aorta.
Coral reef aorta.
Okay. So if the patient has a severe recurrent distressing episodes of flash pulmonary edema, even if the patient is in ESRD, there is still a room for intervention, just to control this. What is the other name for this flash pulmonary edema? What is the mechanism?
Cardiac asthma.
What is the mechanism of flash pulmonary edema? Why they develop severe breathlessness and pulmonary edema? As the patient is, why the patient was not considered for peritoneal dialysis? Because she had multiple access failure.
Actually, she was not given an option of peritoneal dialysis as per the history, and there are few more sites still left where we can plan access for her. The left side of the neck is untouched. Even the right arm is still not yet used for fistula, and the current access is functioning fine since the last 3 years without any flow or thrombus related issues or any intervention required.
Suppose if this patient is gradually, while on dialysis, complaining of difficult to control hemostasis following dialysis, what will you suspect? And what are the consequences of this finding?
Difficult to control bleeding is usually secondary to a outflow stenosis.
First
Or-
thing is, you have to do a heparin modeling.
Yeah.
Maybe high for her, so that should be controlled. Then
Then to rule out other bleeding diathesis,
Okay.
platelet dysfunction, and
even with a low platelet, can you get fistula thrombosis?
yes,
What is it?
heparin-induced thrombocytopenia.
How will you? What precautions you will take when you cannulate a AV graft?
Uh, Buttonhole technique should not be used for cannulating AV
While
graft.
removing the cannula after the dialysis, what are the precautions you take? It is slightly different from that of AV fistula. Okay, you can read it. Now the patient is being registered for the deceased donor.
Yet to be registered.
Okay, so what are the options you will give, like deceased donor cadaver? So regarding the quality of the donor organ, for a diabetic patient, 5 years, 50 years of age and 5 years dialysis vintage, what is the advantage of undergoing a transplantation in this patient?
The outcomes will be same as the patients not on diabetes, and but the option of living donor is not there in her case. So we have to explain her about the
What is the advantage of a transplant in a diabetic patient?
Reversal of cardiovascular. There is reduction of the cardiovascular risk. If the patient continues on dialysis, the risk is still high, and even control of diabetes can get better, and
Quality of life?
quality of life will also be better. Anemia improvement.
What will you tell the patient about the donor organ? What is KDPI?
Kidney donor predictive index.
Profile index.
Profile
What are the
index.
factors taken into consideration?
Patient's age, hypertension, whether it is cardiac death or not.
Many factors: hypertension, diabetes, viral markers,
diabetes.
hepatitis B, C. Several factors are there. So based upon that, you decide the quality of the donor organ.
kidney.
So suppose if the diabetic patient, 50 years, you are getting a KDPI of more than 85. Do you advise them to accept or not? 50, 55 years, dialysis vintage of 5 years?
Yes.
Yes. Suppose if that patient for less than 40 years,
Then we'll have to choose a KDPI of lower
lower
KDPI.
KDPI, lower KDPI. Suppose if you have a patient diabetic nephropathy with a KDPI of less than 40 years, so how do you decide upon accepting a high KDPI
Less than 40,
donor organ?
but donor high KDPI. Mainly patient preference.
Less than 40 years, definitely the KDPI should be, they should not accept a high KDPI. So longevity is also more for these patients. So the acceptance is decided by the patient's age and KDPI. And if you are getting a diabetic donor, will you accept for a diabetic recipient?
Yes.
What are the parameters you will consider?
The latest revision in the guidelines for accepting diabetic donors, usually the diabetes duration should be less than 3 years, and patient should be more than 55 years of age.
More than 3 years, not less than 3
Sorry, more than 3 years. 5 years of, 55 years of age, more than 55 years of age, and no diabetic retinopathy or macrovascular complications, requiring not more than 2 medications to control the sugars, and HbA1c at 2 points in the last 2 years should be less than 7.5, and no proteinuria.
No hypertension.
No hypertension.
Okay. So you said this patient was started on dialysis twice a week. Why?
Yes.
And what is this called?
Incremental dialysis.
Incremental dialysis. So what is incremental dialysis?
Based on the patient's general health and choices, because this patient is traveling almost 50 to 60 kilometers for her dialysis, as there is no good dialysis
It's
center.
not choice, it's more important than that.
Residual renal
Residual
function.
renal function. So residual renal function is good, they can be started on twice a week dialysis. But these patients has to, what is the precaution you should take when you are starting a dialysis with a less dose and you want to increase over a period of time? They need to be regularly monitored.
For residual renal function, avoid nephrotoxic agents and fluid restriction, salt restriction, antihypertensive medication compliance.
So all measures to preserve the residual renal function that should be followed, but more than that they need regular monitoring. Subsequently what happens over a period of time, the residual function will fall down.
goes off.
But they're always kept on twice a week dialysis or inadequate dialysis dosage, and they'll end up in complication. That's what is happening to this patient, isn't it?
Yes.
So after almost 5 years of dialysis, still you said she's
Still on
on
twice a week,
twice a week dialysis. What is the urine output now?
200 ml
200
approximately
ml.
per day.
So do you think it's inadequate dialysis for her?
No.
Okay, and you also mentioned about what do you call the dry weight of
72.5,
72, and interdialytic weight gain
2.5 to 3 kg.
3 liters. Can you say it is dry weight, and how do you achieve a dry weight?
Dry weight is clinical.
Yes, it's a clinical diagnosis only.
So we have to look for patient blood pressures, edema status, nutrition, intake, appetite and intake.
Okay, you still want to continue twice a week, or you want to increase the dose now?
In her case, actually, on examination, her pressures were on the higher side, and she was already on three antihypertensive medication, including a diuretic. So, ideal is to prescribe her for a thrice a week dialysis.
Okay, and you said patient is on erythropoietin.
Iron injections.
So how do you manage the anemia?
She remembers her hemoglobin to be 11.5.
So 11 point, you think it's normal?
Yes,
It's normal for her?
yes.
And what is the recommendation as per the guidelines?
10
What
to
should be the-
11.5.
In females, what should be the target, and males, what should be the target?
10 to 11.
When do you start erythropoietin? And you said she's taking erythropoietin. When do you start erythropoietin? Investigation was
hemoglobin
provided to
is
you?
below 10?
Investigations? She
No.
only said, or investigations were provided to you?
No, 11.5 she remembered because it was done recently. So once the hemoglobin is below 10, and if the iron stores are adequate, then we can start erythropoietin.
How much, what is the dose, and how we have to increase the dose to achieve the target? Though she has a hemoglobin of 11.5. Okay. Any newer agent?
Desidustat. HIF PHI inhibitors. They are oral medications, and cost wise also less costlier than erythropoietin.
So how do they act and what is the side effect?
They are HIF PHI inhibitors, that is, they induce hypoxia, leading to increased erythropoietin production from our own native kidneys.
But
And,
kidney is not functioning, no? So already kidney is gone. So do you think there is endogenous production of erythropoietin from the kidneys?
Yes, and also from the liver.
So there are extra renal production
Extra-renal.
of erythropoietin. Okay. And they contribute more in case of ESRD patients.
What are the reasons for refractory anemia in dialysis patients?
Refractory anemia, one is compliance with medications. Then to rule out other causes of anemia, like vitamin B12 deficiency or folic acid, or to rule out hemolysis or losses elsewhere in the form of GI losses. Then resistance to erythropoietin, antibody production to
Any association with axis and anemia? Type of axis? Does it have some bearing on anemia?
AVF, arteriovenous fistula have a better anemia control because of less risks of hemolysis,
For tunnel catheters,
increased risk of hemolysis,
inflammation,
inflammation.
CRP and all will be elevated, ferritin and all. Then anything else, the patient is found to have, upon evaluation, found to have pancytopenia.
Parvovirus infection or
Parvo-
aplastic anemia.
That is RBC only, selectively RBC is lost. I am telling pancytopenia. What will you suspect? This patient has hyperparathyroidism. Hyperparathyroidism, severe hyperparathyroidism can cause bone marrow fibrosis. That can cause. When will you refer the patient for AV fistula? Usually.
When we refer,
Any change in the
we
concept?
should counsel the patient once the GFR drops below 30 ml per minute, and
Now, what was the previous concept? What is the change in that concept now?
now we have to refer the patients at less than 15 ml for AVF creation.
It's not ML. It's not with respect to what is called the
GFR.
GFR.
What is the advantage of creating AV fistula early? What is the current consensus on that?
One is
Very early.
One is patients' compliance and visits to the hospital will be regular once they are created on AV fistula, and then
Does it have some effect on the progression of kidney disease? Early creation of AV fistula? Any recent?
they say it prolongs the progression of CKD, but the reason being is patients' regular visits to the hospital once the fistula is created, and
How it prevents the retardation of, how it retards the progression of CKD to ESRD, the early creation of AV fistula.
Okay, this patient had fistula complications, no? I mean, how many fistulas were failed?
2 primary failure, and third one is functioning.
So, when do you define it as a primary failure?
Primary failure is when the fistula after creation we have not been able to use it despite of any surgical or endovascular intervention.
So, what is the reason for the primary failures of the fistula or access problems in this case?
In this case, she is a long-term diabetes, so poor vessel.
Microvascular complications can be one of the reasons. Okay, how do you mitigate that? Okay, now our patient is on access. What is the access now?
Now it is proximal RCA AVF in the left forearm.
Okay, and how do you do a fistula surveillance now? Because she has complications, multiple complications.
Yes.
How to do a surveillance? Because he is in your dialysis unit now.
We have to edge fistula when patient is at home and to report early. Then during dialysis, we have to check for the flow and any increased venous pressures or decreased arterial pressures, any dilated veins visible, local examination, swelling of arm, increased bleeding post closure of fistula. And
Same thing,
also
inspection, palpation, everything, the same thing should go. Inspection, they should be, you should look for the swelling.
and also see for peripheral circulation. Then blood pressure control during the dialysis to avoid intradialytic hypotension and then palpation, we have to see for the thrill, and we can check for pulse augmentation. We can do pulse augmentation and arm elevation test to see for outflow and inflow stenosis. And
Pulse augmentation is for outflow or inflow?
pulse augmentation is for inflow stenosis, and arm elevation is for outflow stenosis.
Okay, so how will you correlate with these inspection findings with the dialysis findings? So what will happen in inflow stenosis and what will happen in outflow stenosis?
In outflow stenosis, there will be increased venous pressure and also bleeding post closure. And inflow stenosis, there will be more negative pressure in the arterial pump.
And we can't achieve the blood flow rates.
Blood flow will not.
And it will be progressive. You see the progressive fall in the blood flow rates and decrease in the increase in negative pressure. You should think there is something wrong with the fistula. So you should be very careful with this patient because he has subsequent access failures. Okay. Anything else? Yes, no, okay, so I think you did well.
Thank you.
Thank you.